Good morning, guys. Tony Maritato here, licensed physical therapist. So this is a new video format that I want to try. I want to watch the Al Roker interview where he had his knee replacement. He was talking about physical therapy. This took place about 7 years ago. I want to watch it with you. I want to discuss it. I want to share some perspective on it from me, a physical therapist, watching somebody else go through this experience. So let me play a little bit of the video and then I'll kind of talk as we go through it.
How you feeling?
Well, I'm feeling okay. I mean, a little ouchy, but for the most part, I feel better than when I went in. So that's the most important part. Technology and procedures have come such a long way. Doctors want you back up and moving as soon as possible. And that meant house calls from one tough physical therapist.
So he said, I'm feeling a little ouchy, but better than when I went in. Now, we don't know how far post-op he is when he made that statement. In the video, he says that he's 2 weeks post-op. You can see here, I mean, I'm shocked, truthfully, at 2 weeks. His incision is almost invisible. It's amazing. You can certainly see the swelling in the surgical leg compared to the non-surgical leg. You can see during certain things, he's going to grimace. He's really pushing himself through this. But for being 2 weeks post-op and doing as great as he is, that's amazing. Let's watch a little more.
You'd think that if you get knee replacement surgery, at least you'd get a little rest, right? Wrong. Not the case when your physical therapist is a 6'4" former college linebacker, Billy Campbell of the Visiting Nurse Service of New York.
Well, I'll try to be as gentle as possible.
Since when? He measures my progress. How far can I bend my knee?
Breathe.
So let's talk about what's going on here. What's happening is the therapist is using a goniometer to try to measure knee flexion. There's 3 ways that we measure knee flexion and knee extension. One is called active range of motion. That's when you're moving the knee by yourself with no outside assistance, just the normal muscles. 2 is passive range of motion, when the therapist is moving the knee for you and you're not helping in any way. And then, of course, active assisted range of motion is when both you and the therapist are working together to achieve full range of motion, either in bending or in extending. Now, if you notice something that's particularly not discussed nearly enough, he's using a goniometer. I use a goniometer in my clinic as well. You're using these 2 arms of the goniometer, trying to line them up with certain bony landmarks. But I promise you, if you look at the clinical research, that goniometer is inaccurate between 5 and 10 degrees at any given time. So even for myself, if I measure the same patient, same knee, same range of motion 3 times in a session, I'm going to get wildly different numbers between 5 and 10 degrees different. So don't get too hung up on what the numbers mean. I mean, you're eyeballing it. You're making your best guess. You're trying to line up these landmarks. It is not an accurate form of measurement.
Good. 113.
So he says he's at 113.
Excellent.
We're gonna remove all those bone spurs.
Remember, I had that right knee totally replaced less than 2 weeks ago.
Now, look at that shot right there. I don't know about you guys, but that is not a straight leg. And so Al Roker is under anesthesia. He is not awake at this point in the procedure. I'm assuming that's the surgeon. But when he's holding him up, supporting by the heel, that leg should be completely straight. That is not a completely straight leg. I just found that interesting. I don't know. So in other words, if Al now goes into physical therapy post-op and they're struggling to gain full extension, to me, that doesn't look like full extension. What do you guys think?
Weeks ago. We focus on 3 things to get me back and moving.
Said they focus
First,
on 3
strength.
things.
We're trying to get that last bit of extension in the knee and get these quadricep muscles to fire nice and strong.
So I'm going to get a little nitpicky here. Yes, strength is an important element, but there's different aspects to strength. So somebody who has not had knee surgery, who doesn't have any knee problems, when you talk about strength, you talk about their ability to squat, their ability to press, their ability to contract the muscles, the quadriceps, the hamstrings, the calves, and generate force. In this scenario, especially after a knee surgery like this, when we talk about strength, we're not talking about that kind of strength. It's probably not the right word to use. We should talk about neuromuscular control, because that's really what we're talking about. If you had a knee replacement, you probably had a challenge lifting the leg, extending the knee, not just because of knee tightness, but because the muscles, the quadricep muscles, just weren't functioning the way they're supposed to. And part of that is the neurologic control of those muscles. So I don't like to use the word strength in this scenario. I would rather use neurologic control.
It'll help keep your knee from buckling when you walk.
Billy puts me through a series of exercises.
2.
Next thing we focus on, balance. This makes sure I can move around safely.
If you're not stable on one leg, guess what? You're not stable walking.
And so the same thing, when we talk about balance, there's different kinds of balance. There's the vestibular balance, which is controlled by the inner ear. There's proprioception, which is I can't see my hand, but I feel it and I know what it's doing in space because I can get the information from the nerve endings. And then there's balance associated with either like just weakness, deconditioning, muscle atrophy. If I tried to carry too much weight across the room, I would look off balance because I wasn't strong enough to do it. So yes, we always want to work on balance. I work on balance from day number 1, but it's important that you understand there's different kinds of balance.
Finally, agility, combining strength and balance.
With the new prosthetic knee, your brain and your knee don't talk to each other.
So it doesn't.
And that's, he said, your brain and your knee don't talk to each other. That's the proprioception, the neurologic control. That's the stuff that I think is most important. A lot of the agilities we do right from the beginning, these are things that we don't necessarily want our patients doing alone because it does increase the risk of falling or having other injuries. So when you're with a physical therapist, either in your home or in the clinic, the proprioceptive training, neuromuscular control, these are the things that you're really going to work on with your therapist. The other stuff like the range of motion and reduce swelling and things, that's stuff that you can do at home alone safely.
Know that there's something not there.
Right.
Some fencing style lunges, and we're ready to take a stab at the stairs. Good thing, because I live in a brownstone with plenty of stairs at home and at work.
Beautiful.
So if you notice, he's doing repeated step ups on the bottom of the stairs. I'm sure in their therapy sessions, they go all the way up and go all the way down. But when we're talking about training, we want to maximize safety. So whether you're doing the bottom step 10 times or you're walking up 10 steps, you get the same benefit, but you increase the safety when you just focus on the bottom step. Right in this still frame, he's doing an extension hamstring stretch. Now, if you notice, once again, that is not a straight knee. So that is about the same angle that the knee was when he was in surgery. And we saw that early video footage. He's in the same position. So I don't know. I mean, certainly he can always improve into greater extension, but I don't want patients to think, oh, well, you know, in surgery, I got full extension, but now I'm lacking 3 or 5 degrees of extension. That's not full extension.
Billy says I'm not doing too badly.
There's not a lot of people this early on after knee surgery that can do some of the things that he's doing, like the step
I agree. I mean, he's 2 weeks post-op. He's doing amazing.
ups on the stairs.
Then after Billy's session is over, it's time to ice that leg with a high-tech cold compression.
All right, so Al's using a Game Ready. A Game Ready is a multiple thousands of dollars. It's an awesome device. We've used them in the clinic. We've used them with athletes. You fill that compartment with ice and water, but you can get less expensive versions of this. I've got other videos on the channel where I show how to use the $300, $400 versions of this. Or you can just use an ice pack with a compression wrap. It really kind of does the same thing.
Machine, my new best friend.
So Al's using a wedge pillow.
baby.
I like placing people on a wedge pillow. I think it elevates the leg. It provides for extension. It's pretty comfortable. You know, that is a good level of extension, what you saw there in that final picture. Let's hear Al's closing thoughts and then we'll wrap this video up.
It's really interesting because they do get you up right away.
Yeah.
And now I'll transition to outpatient physical therapy, so 3 to 4 days a week. But that's the most important, you know, the rehab and the physical therapy.
You had your other knee.
Outpatient physical therapy 3 to 4 days a week. Now, closing thoughts, you guys are able with most insurance coverage to receive outpatient therapy in the home if you're not able to get to an outpatient clinic or your surgeon did not order in-home physical therapy for you. Outpatient providers can come to your home. So guys, if you like this video format, let me know. I'm always looking for better ways to provide you guys with the value and answer the questions that you need. I'll catch you on the next video.